Okay, I'm probably gonna start us off just so that we leave enough time for questions at the end. So welcome everyone. And just to say that we'll do the questions at the end through the chat box. If you just post your questions in there, then I'll pick them up and pose them to Harry. So yeah, welcome everyone. I'm really delighted to welcome Professor Harry Rutter to talk to us today. It's been a while planning. We got interrupted by COVID, etc. So it's really great to have Harry here today. So I first became aware of Harry through his excellent work related to tackling obesity using a complex systems approach. And as many of you, I'm sure, will be aware, we've had limited success with our intervention policies to date to address obesity, many of which are very kind of individually focused. And Harry's work goes beyond the individual to consider complex systemic influences on our behaviour, which I think I and many others think is a way forward to tackle many of our most wicked health problems. So Harry is a Professor of Global Health at the University of Bath. He's also adjunct professor in Norway and in Ireland. His research focuses on effective ways to improve the research, policy and practice responses to complex systems problems in public health. And he has a particular focus on non-communicable diseases. He's a senior strategic advisor on obesity to Public Health England, and he was the founder of the National Obesity Observatory for England, where he led the development of the English National Child Measurement Programme and Child Obesity Surveillance System. He also chaired a NICE Programme Development Group for guidance on measuring and promoting walking and cycling. And more recently, he's been involved with the government's SAGE committee, and he's co-chair of the Lancet Chatham House Commission on improving population health post-COVID-19. And I think he's going to say a bit about that today. So very, very big welcome to you, Harry, and you're going to talk to us today about chess, not checkers, the need for a complex systems approach to public health. Take it away.
Thanks very much, Sharon. Can you see my screen?
Yep.
Great, thanks very much. Hello everyone. I can't see any of you, but I hope you're there, and I won't be looking at the chat while I'm talking because it just distracts me and takes me off track, but I hope to be answering some questions towards the end. I thought I'd start by focusing on the kinds of things that I've mostly been working on for the last 10 to 15 years, and really the kinds of things that got me into thinking in and working on complexity. And if we think about what's driving obesity, it's pretty clear, really. It's too much of this and not enough of whatever these people are getting. But if you read the newspapers, if you listen to the politicians, if you make the mistake of looking at the below the line comments in a newspaper, what you'd think is that the drivers of obesity are actually down to things like population stupidity, laziness, and greed. But of course, for those to be the drivers of obesity, these ridiculous charts would have to be correct. If the obesity epidemic was explained by laziness and greed, surely those would have had to have increased in line with the obesity epidemic, which of course I don't believe, certainly they haven't. I'm perfectly happy to accept that I'm lazy, weak-willed and greedy, but I don't think I'm any, or my generation is any lazier, greedier or weaker-willed than my parents' generation. So what's fundamentally shifted is not us as people, it's the environment around us. Now, this may not quite be downtown Glasgow, but the food and physical activity, the physical, social, economic environment that this image represents is one in which it is absolutely, of course, it is possible to engage in adequate physical activity. It is possible to eat healthily, but the cues, the odds are all stacked against us. And importantly, of course, as we all know, those odds are stacked against us differentially in terms of social position. There are really, really powerful and important inequalities in terms of the opportunities we have and the environments that we engage in our daily lives. And that creates a set of challenges for public health. I think we've managed to get pretty broadly beyond the idea that there's any one thing that needs to be done to tackle a big messy problem like obesity. And one of the ways that I like to think about this is to think about it as building a wall of sandbags against a flood. And I think this is pretty well accepted now. There's lots of rhetoric about no magic bullets or no silver bullets. There are many, many things that need to be done, and no one of them on its own will solve the problem. You actually need the whole set of measures, a whole wall of sandbags to prevent this flood, whatever it might be. But when we look at the ways in which our research gets done, the kinds of things that tend to get funded, all too often what we find is that the research system pushes us to take one of those sandbags out on its own, or maybe with a couple of others, and test them to see if they stop the flood on their own. And I've lost count of the number of research proposals that I've seen in one way or another that broadly say, we're going to examine one small part of this big, messy, complex system, and we're going to measure the impact of it on this distal outcome. In terms of what we're talking about now, it might be obesity, but it applies across public health. All too often, we are expected to identify the relation between a single contributor to a big problem and that outcome of interest. And I think that creates a huge challenge for the nature of the evidence that we're generating and the kind of evidence we're able to adduce when we're working out how to respond to these kinds of problems. There's another set of challenges around the kinds of the conception of the kinds of interventions that we may be wanting to put into place. And if we go back to Jeffrey Rose and his prevention paradox and his point about the difference between a risk reduction approach and a population approach, what we see is that this kind of idea that we need to identify a discrete intervention and measure its effect on a defined population kind of pushes us towards looking at the risk reduction side of the kinds of things that Rose was talking about. It's much easier to get funded for a project that says, we're going to look at a definable endpoint in a defined population, 300 people in an intervention arm, 300 people in a control arm, 12 months before and after. We've done the power calculations. We're going to see if this intervention moves a proportion of these people out of the high risk category into the normal range. Much easier to get that kind of research funded than to say, we're going to look at tiny changes, perhaps unmeasurably small changes across millions of people over the medium to long term. And this challenge, where much public health activity is actually about shifting risks across across large populations, but perhaps shifting any one of those risks by only a small amount in any one individual, this creates a tension in the kind of evidence that we have lying around to help us answer challenges such as obesity. And perhaps slightly flippantly, I kind of put this into something that I ended up calling the dangerous olive of evidence. It's just a Venn diagram, but I was at a conference with a bowl of olives in front of me while I was putting my slides together, so I made it an olive. And it's a big, fat, fleshy, juicy olive, and the flesh of the olive represents all the things we could possibly do, in this case to tackle obesity, but it could be anything. It could be inequalities, it could be knife crime, it could be young people's mental health, whatever it might be. The flesh of the olive, the bulk of this Venn diagram is is the range of possibilities, the things that we don't yet know whether they work or not, but they seem like potentially useful interventions. The olive is then stuffed with a pepper, which is the subset of those interventions for which we do actually have some evidence of effectiveness. Someone's done some research, people have collected the evidence, and we've got, of all those good ideas, we've got a subset of those for which there is actually some evidence. And the pepper is stuffed with a really quite small piece of garlic, which is the subset of those interventions, so the interventions for which we have evidence of effectiveness, for which we also have evidence of cost effectiveness. And in the certainly within I don't know what you're like in Scotland, maybe you're doing much better than us, but the public health system in England has no money. They're unbelievably short of resources, and in that kind of environment, arguing not to do the kinds of interventions that we know to be demonstrably at least effective, if not cost effective, would surely be completely untenable. Well, the trouble is, of course, that the kinds of interventions that sit within the pepper and the garlic, the kinds of interventions for which we have that sort of evidence, tend to be particular types of interventions. And if we look at this image that came from a 2011 Lancet paper by Boyd Swinburne and colleagues on obesity, what we see, we can see why that might be. So the range across the top is from big picture structural environmental upstream measures over on the left, through behaviors and down to individual level physiology on the right. And if we think about the kinds of things that we might do to tackle obesity, what this means that on the right, we've got interventions such as drugs, or at its most extreme, bariatric surgery. We then go through things like health promotion programs, social marketing, weight management programs, that kind of thing. And then over on the left, we come to the policy interventions, whether they're trying to shift the physical environment or the food environment, whatever it might be. And perhaps the most extreme left example of a really upstream policy here on the left-hand side of this diagram would be something like a really meaningful, serious carbon tax, not the kind of $60 or $70 a ton that people talk about, but maybe $1,000 a ton, you know, something that really, really reshapes the food system, reshapes our physical environments, changes the way we move around, and so on and so forth. So we've got this range from the extremes of fully reshaping our environments in response to something like a carbon tax, changing things like agricultural policy, changing the ways in which we plan our towns and cities, down to the other end of bariatric surgery. But one of the things that Boyd put on this chart was this wedge at the bottom that says population effect and political difficulty. So if you take something like bariatric surgery, excuse me, which in the right individuals, absolutely not for everyone, but in the right individuals, it can be transformational. You can reverse someone's type 2 diabetes within a week. It's a really powerful intervention. But one of the indications from NICE for bariatric surgery is a body mass index above 40. And I think in the UK, we've got something like 1.5 million people with a body mass index above 40. Now, I'm not for a moment saying that every one of those 1.5 million people should have bariatric surgery, far from it. But that's one of NICE's indications, BMI above 40. So we've got potentially 1.5 million, in fact, more than that, because there are other indications, 1.5 to 3 million people for whom bariatric surgery might be indicated. But we do 6,000 of those operations a year. So it could be completely transformational for those individuals. But as a population level health measure, it's basically irrelevant. 6,000 operations when the level of potential need in the population is maybe measured in the millions. Up on the but you can do a randomized controlled trial of bariatric surgery or not. So you can get really robust evidence on that. Up at the other end of the scale, we've got things like carbon tax that I mentioned, or reform of agricultural policy, that kind of thing, really reshaping the amount of fat and sugar and energy that goes into our food system. Those kinds of interventions could have a really powerful effect on population level health, but they're politically really hard to do. And of course, you can't do a randomized controlled trial of reforming agricultural policy. There have been some attempts to do trials of within country of sugar tax type interventions. I think Norway have done something within regions looking at food related fiscal measures, but you can't really do a randomized controlled trial of a sugar sweetened drinks tax. It's too easy to get around it. Excuse me. So we have this mismatch where the evidence base is skewed towards these kinds of interventions, the individual level interventions on the right-hand side. You can randomize someone to receive bariatric surgery or not. You can randomize someone to a 12-week weight management intervention or not. But you can't randomize the big picture structural upstream measures. So we've got an evidence base that is hugely skewed towards these individual level measures and away from the large-scale population level things that may have a bigger effect. At the same time, we've got the public media and political discourse that individualizes a problem like obesity. It conceptualizes it as a failure of the individual down to willpower, greed, and so on, when in fact those can't possibly be the explanations for the global, let alone the national epidemic of obesity. So we've got two different strands individualizing what is in fact an environmental population level problem. So I kind of don't blame the politicians for saying they've got a mandate to act at individual level, because both the scientists and the media and the public are telling them that the problems and the responses sit on this right-hand side of the diagram. So the reason I regard the olive as dangerous is that the olive, the things that sit within the pepper and the garlic, the evidence pushes us towards the things that are potentially, they may be more politically straightforward, but they are potentially much less effective at population level. And this plays out in policy. If you look at the WHO Commission on Ending Childhood Obesity that came out, their report came out a few years ago, they've got something like 34 recommendations. And I think 17, I think that's 17 on the left-hand column, 17 of their recommendations relate to individual level agentic interventions. So something like front of pack labeling might look like a population level upstream measure because it might be put into place through policy, but it actually operates at a level of individual agency. So I've got to look at the packet, I've got to want to look at the label, I've got to interpret what the label says, I've got to make a purchasing decision based on what I've seen on that label, all of those things. So it is actually quite an agentic intervention. So we've got I think out of 34 recommendations, something like half of them relate to individual level measures. 5 of them relate to the behavior of the corporations that are hugely influential in shaping the environments within which we make all these decisions. And one of the reasons for that is the nature of the evidence base that was fed into this commission. So what do we do about this? Well, I would argue that one of the things that we need to do about it, and that's kind of the point of this talk, is to think about systems. And I think it's important to think about complex adaptive systems, but let's start just by thinking about what a system is. What does a system look like? And without even realizing it, long before I started doing any work on complex systems, about 20 years ago, I was doing some work on transport, and I came up with this question of whether or not seatbelts caused obesity or non-communicable disease. And the point here is, if you start on the left-hand side, seatbelt usage as a safety measure, may, through the mechanism of risk compensation, lead to vehicles going faster. As a general rule, safety benefits in vehicles are consumed as performance benefits. So having anti-skid brakes in your car, which mean you can stop in a shorter distance on snow or ice, doesn't actually mean that you stop in a shorter distance on snow and ice. It means that you're able to drive faster on snow and ice than you otherwise would, and you'll stop at an equivalent distance to that which you would have stopped at before. So in general, safety benefits are consumed as performance benefits. Increased speeds will lead to increased danger, and importantly in terms of behavior, increased perceived danger. Biggest disincentive to walking and cycling in this country is perceptions of danger. So increased danger, perceived danger, less walking and cycling. At the same time, we generally, many of us are exceptions. The pandemic clearly has changed all of this over the last year, but in normal times, we generally, most of us, have a constant travel time budget, known as the Marchetti constant, of about an hour a day. All other things being equal, if vehicle speeds go up, trip length goes up. If trip length goes up, it means you can live further from where you work or where you shop or where you study. So all other things being equal, as trip length goes up, that's likely to lead to sprawl, as we see in with the preponderance of out-of-town shopping centres here. We see it absolutely in the United States. The further apart destinations are, the less likely it is that people can walk or cycle between them, less physical activity, more non-communicable disease. And of course, if we've got more journeys going further, that means more air pollution, and that's a separate independent route into non-communicable disease. The point of showing you this is not to say that we shouldn't be having seat belts. It's to see that this is a system, and failing to follow through, whether or not this is correct isn't the point. This is a sort of hypothesis, but the point here is that if this is correct, thinking about this as a system might allow us to see not that one shouldn't have seatbelt usage, but that we should try to mitigate the harmful unintended consequences of that, such as increased danger, increased trip length, air pollution, non-communicable disease. Seeing it as a system might mean we respond to it differently. I wanted to do a slight aside here to COVID-19, because I think one of the problems we've seen over the last year or so with this pandemic is that COVID has, in general, not been treated sufficiently as a system problem. And I mean, please don't do anything with this. This is just musings from myself about some of the factors, absolutely not a comprehensive map at all, but some of the ways in which things play out in COVID-19. So we've got things up here to do with inequalities, poverty, ethnicity, precarious employment, and the ways in which those factors relate to whether or not one can work from home, one's likelihood to get vaccinated, economic costs, how that relates to NHS capacity, and so on and so forth. The point is not whether or not this is a true or correct map. The point is that thinking about the ways in which things interact can help us to identify possible ways to mitigate some of the harmful effects. But there are other ways in which I think it's helpful to think about COVID as a systems problem. The default narrative is one that says, oh, this came from a bat in a wet market in Wuhan. And of course, that may or may not have been the final step in the transmission of SARS-CoV-2 from animals to humans. But without overcrowded, high-density cities, without global hypermobility and people moving this virus around the world at extreme rates early on and still, without high levels of urban air pollution, without a high existing burden of non-communicable disease, whether it's respiratory disease related to tobacco or obesity, which has been a particular problem, without the kinds of environments that I showed earlier, things would have played out very differently with COVID. And all of these things are related. We're also seeing the ways in which corporations have responded to COVID-19, with the tobacco industry pushing in, seeking marketing opportunities. The NCD Alliance and the Spectrum Project have done some really great work, pulling together a load of case studies of the ways in which unhealthy commodity industries have responded to COVID-19. So here is an adaptation within the system. We get a pandemic, we get a disease, and we see the ways in which industry responds. Equally, one of the factors underpinning COVID is the ways in which, or pandemics in general, is the ways in which ecosystems have been degraded, moving animals and humans closer together, increasing the propensity that these kinds of zoonoses will get spread. One of the really big underlying factors underpinning that ecosystem degradation is the climate emergency. But of course, last year, COP26, the climate conference, was postponed, delaying further the urgent action that is required. So the point here is to show that, COVID is a systems problem at multiple different levels. It's a systems problem within the UK. It's a systems problem within any town or city, but it's also a global systems problem. And this is something that with my colleague Teresa Marteau, I'm looking at. There's a group of us on the Lancet Chatham House Commission on Population Health post-COVID-19, where we are looking at these links between non-communicable disease, infectious disease, and environment. And I think while we are all rightly focused on the current horrors, particularly we're seeing in India right now, the horrors of COVID-19, we've seen, 3 million deaths globally from COVID. We get over 40 million deaths a year from non-communicable disease. And I think it's really important that we don't forget about the hugely important and dreadful burden of NCDs through all of this. So that's systems, but what about complexity? And trying to convey the nitty-gritty of complexity in 5 minutes isn't straightforward, but one of the, I think the key principles here is the difference between things that are complicated and things that are complex, things where the relations are fundamentally linear and those where they are non-linear. And one of the examples I like best for this, I've been using for a long time, is the difference between a Saturn V rocket, which is a hugely complicated piece of machinery, thousands, if not millions of parts. But if you know what you're doing, you can put 3 people in this little cone at the top. You can press the launch button, send them off to the moon, and whenever it is, I don't know, 5 days later, whatever it is, we know exactly where to pick them up from, to within a few hundred meters and a minute or two, subject to the winds. We know what to do. It's incredibly complicated, but it is also manageable and controllable and predictable. It's complicated, not complex. The Afghan War, however, represents a different category of set of challenges, a different category of problem. And however much one knows about narcotics or insurgents or government capacity or whatever, there's no one thing here where you make something happen and it flows through in a standard, predictable, linear way across that system. Wherever you intervene here, there are ripples and ramifications through the rest of the entire system. It's not the same as saying there's nothing you can do about it. There are all sorts of things that can be done. Some have been more effective or less ineffective than others, but expecting any of those things to have the same kind of linear cause and effect relations that one sees in a Saturn V rocket is, I would argue, delusional. And of course, the reason I showed this map of Afghanistan is because in many ways, if you half shut your eyes, it looks a bit like the foresight map of obesity from 2007. So I don't know if anyone hasn't seen this before, but broadly, this was a map from the Foresight Report on Obesity. Broadly, we've got physical activity on the right-hand side, food and nutrition on the left-hand side, social, cultural stuff at the top, and biology, physiology, genetics, and so on down at the bottom. And in the middle, we've got a sort of hunter-gatherer energy balance loop in which we've evolved as hunter-gatherers. And if you see a woolly mammoth, you kill it and eat it. And if there are no woolly mammoths around, you sit in your cave conserving energy with your feet up watching telly. So the physiology of obesity is one that is actually a survival mechanism if you're a hunter-gatherer, but in the kinds of environments that we now live in, it's potentially really harmful. The point of this map, which is, I think it's had lots of criticism, some of which I think has been reasonable, some of which I think has been unreasonable. For me, the core point of this map is not to worry about any of the detail in it. It's to see the category of problem that we face with obesity, to see that this is not a simple, straightforward, linear problem, however complicated. This is a complex problem where if you intervene in one part of the map, you get ripples, ramifications throughout. So physical activity over here, the best donuts I ever ate were at a Department of Health regional obesity leads meeting in about 2009. I'd taken my Brompton folding bike on the train to London. I'd cycled hard across London from Paddington to Wellington House, burnt, I don't know, 250 calories getting there. Lovely pile of donuts on the table. I crammed 2 of them in. That's about what, 600 calories. So I'd burnt my energy getting over, and I had consumed more than that, apparently replenishing my stores. These things are related. And I think failing to see the ways in which we have these kinds of responses means that we miss the point of what needs to be done. The last bit of this triad, I think, to examine is adaptation or adaptive in the context of these systems. And this often gets forgotten, but in scientific terms, I think it may be the most important, because it helps to explain why all too often, I think we don't find answers to the questions that we're seeking. So if you think about a simple logic model for how a sugar sweetened drinks tax might work, it seems pretty straightforward, doesn't it? Bring in a tax, price goes up, sales go down, consumption goes down, obesity goes down. And I would argue that for this logic model, actually, the only bit of evidence you really need is for this arrow here, which is the price elasticity of demand of sugar sweetened drinks. And we know that if you put up the price of things like that, sales go down. But of course, it's not this simple, because at every step along the way, the system adapts in response to these interventions. Before the tax even comes in, industry pushes really hard to try and stop it happening, or if it does happen, for it to be set at such a low level that it's meaningless, and a year or two down the line they can say this was futile and it gets withdrawn. There can be other responses. Some of them are positive. So the great thing about the sugar sweet drinks tax that we have in this country is that it was set at 2 different tiers, and it led to very significant reformulation before the tax even came into play. Something like 1/3 of soft drinks had reduced their sugar content below the taxation threshold. But there are other ways in which price structuring, prices get restructured, things get reformulated, and so on and so forth, down to on the far right-hand side of this diagram, we get things like right-wing think tanks attacking those of us on the evaluation team to undermine the potential credibility of our evidence. So the point here is that every step along the way, the system adapts, and there are attenuations in these effects. And in fact, for the evaluation, we went away from a simple linear logic model like this and built it in as a system map. So that logic model broadly flows through here in terms of these sort of purple lilac nodes up near the top. But we've built in a whole load of other factors. So we consulted with industry on this. And one of the things they said is, oh, there's going to be terrible job losses. Well, that's what they usually say, and it usually doesn't come to pass, but let's examine that. So if it happens, it's important to know. So we've got stuff about employment up here. I'm particularly interested in the stuff down here about public, political, and media discourse around sugar and sugar-sweetened drinks, and about fiscal measures more generally. I seems to me that we should be treating sugar sweetened drinks tax as a mechanism, a tool to internalize the harmful externalities imposed by sugar sweetened drinks. If that is a principle that gets accepted, that principle of internalizing the costs of harmful externalities, correcting these market failures, promoting a more level economic playing field for healthier goods in competition with less healthy goods, seems to me could be really quite powerful for public health. So let's look at that. Let's see how those kinds of things change. The point here is that systems adapt in response to intervention. And if we ignore that, we risk missing the point and we miss failing to identify potential positive or negative effects from any intervention. So we're not looking at things properly if we fail to account for or anticipate the ways in which interventions might lead to adaptations. The last thing I'd like to talk about is time, because I think this is something that we've kind of lost sight of in public health. All too often, when we're asked what needs to happen, we start by thinking what needs to happen now, rather than what we're actually trying to achieve over the medium to long term. If we look at this chart, which is the trajectory of tobacco sales over the course of the 20th century in the United States, what we see is a pretty steady rise from an extraordinarily low level back in 1900, a pretty steady rise up to about 1960, spent about 20 years bouncing around the top, and then a pretty steady decline ever since. And no one thing has really transformed this curve. Perhaps the biggest effect was US joining World War II, where presumably because of cigarettes in ration packs, soldiers took up much more smoking, but that's probably the steepest single inflection point on here. What we see is that in the US, in 1964, there was the Surgeon General's report. In this country, it was Royal College of Physicians' report in 1963. Those kinds of things were the start of a shift, a change in the ways in which things happened. To the extent that we're at the situation we have now, where we have workplace smoking bans, we have smoke-free legislation, we have plain tax, we have talk of not banning smoking in private cars. Now, I don't think, I mean, people were thinking about these things back in those reports in the early to mid 1960s, but it's taken half a century to get there. And I guess the way to reflect on this for me is to think about, okay, is to think how this relates to obesity. And if we were giving this talk, clearly not over Zoom, if we were giving this talk on tobacco control in 1964, it would be really, really hard for us to imagine a workplace smoking ban, that kind of thing, which must have seemed incredibly radical. It must have been incredibly hard to imagine that happening, because half of us, myself included, would have been smoking. So things have changed, and the things that once seemed incredibly radical have come to pass. So I would argue that we need to think in these kinds of temporal ways about what's going to happen to obesity. So we can imagine a world in which sugar sweetened drinks become not eliminated, but vastly less prevalence, in which diets have changed hugely for environmental as well as health reasons. Massive reductions in meat and dairy consumption, for example, huge shift towards plant-based diets. That stuff's going to happen. Getting from here to there is not the same. It doesn't just involve saying, what do we do now? It involves saying, how are we going to get there? Where do we want to be? And what are the steps along the way? And if we think about some of our interventions, even quite simple interventions, in this slightly different way, it may well change the way in which we put them into place. So if you just take something as basic as a walking school bus, When my kids were at primary school, we did this. You know, we dropped them off half a mile from the school, and a bunch of them they'd put on high visibility vests and they'd walk in a row along the road into the school. And that's great for physical activity among primary school children while they're in primary school and can be coerced into that level of physical activity. But as a public health objective, are we really interested in coercing young children into physical activity, or is the actual objective about increasing population levels of physical activity in equitable ways that reduce inequalities? And if we think about a walking school bus, not as something that we do to affect these kids for a short period of their lives, but actually to try and change the population level prevalence of physical activity, however tenuously we might be able to be sure of that, we might think rather differently about it. We might, for example, think about it as an intervention that habituates kids to the idea of walking, being outside, whatever the weather. We might, very importantly, move away from treating it as a dangerous intervention for which they require personal protective equipment in the form of high visibility vests. And we might place the onus for road safety on the perpetrators of road danger, i.e. motorists, and shift the way in which we use this intervention, not as something where children are cowed by the cars and have to wear high-vis vests, but the traffic is tamed so that kids can walk wherever they like. And if we think about using an intervention like this to help reshape the environment in ways that affect everyone and have potentially much more lasting effects, we might design it somewhat differently. So to come back to Swinburne's diagram, I guess what I'm arguing is that if we're going to shift this from this skew towards the right-hand side here, we need some kind of rebalancing, which doesn't mean we stop doing the stuff on the right. There's still plenty of really important individual level stuff to be done on the right, although we do need to be careful about intervention-generated inequalities. But to move this more evenly across the map, including the more upstream things. And the kinds of ways in which that might happen might include shifting the public media and political discourse. They might not be the immediate obvious things that we would think about. So I was once asked, I read a little piece on this actually called "The Single Most Important Intervention to Tackle Obesity." And for me, the single most important intervention to tackle obesity is to appreciate that there is no single most important intervention to tackle obesity. Equally, I think one of the other really important interventions to tackle obesity is to realize that it is not about the failure of individuals. It is about a set of structural drivers, a set of commercial, environmental, economic drivers of health that reshape the kinds of decisions that people make. And while obesity is characterized in a stigmatizing way that blames individuals for what are actually the consequences of their environments, it's really hard to do the politically difficult upstream things on the left-hand side of this diagram. So a pressing imperative with obesity, it seems to me, is to reframe it from its inappropriate and incorrect framing of an individual level problem to a more appropriate and correct framing of it as a structural set of problems largely driven by the environments in which we live. And that then allows a whole load of other things to flow because it changes the political context in which those decisions get made. Almost done. I just wanted to say that some of these ideas have been described and rehearsed in this paper that we put out in the Lancet. I think I saw Lawrence Moore on the guest list for this a little while back. Lawrence was one of the co-authors. Maybe there are others on this talk, and have a look at that if you want to see some of these ideas in more detail. And I guess the last thing I really wanted to get to was that one of the misunderstandings that comes from this is about the difference between complexity science and systems thinking. And there are many very, very clever people, Lawrence included, who work in complexity science where they build models and they are taking a largely, in many cases, quantitative approach to this. I'm not that smart. I'm way up the other end of this. I guess what I'm talking about here is the kinds of ways in which we can reconceptualize, we can think about the challenges that we face, the ways in which we might deal with them, and at least have some hypotheses that we could test that might help us to deal with some of these problems a bit more successfully and effectively than we currently do. And finally, why was this called chess, not checkers? Well, checkers or drafts is a simple game of tactics. You just make one move at a time. You decide where you're going to go, and you just play the game, and you take other people's pieces or whatever. Chess is a much more strategic game where if you're smart, if you're any good at it, you're thinking 3, 4, 5, perhaps even more moves ahead. You've got an end game in sight, and you've got a plan, you've got a strategy mapped out. You know your opponent will do things that you didn't want him or her to do, and you'll have to adapt to that, but that's okay too. And I think that in public health, all too often, we're playing a tactical game like drafts or checkers, and far too rarely are we playing a strategic game like chess. So I would argue we need to get much better at saying, what's our 20-year vision? What's our 5-year strategy? And what's our 1-year plan? Where are we trying to get to? How are we going to get there? And how do we identify the knowledge that's needed to help us make that happen? Thanks very much.
Thank you, Harry. That was a really excellent, very thought-provoking presentation. So we do have a few questions in the Q&A, and we do have some time to ask those. So there's a few questions from Lawrence in there, and the first one that he's asking was one that I was also kind of thinking about, because we've had a few recent funding applications which have been trying to use a sort of systems thinking approach that have got bounced by funders. And we think that the funders are just that clearly overly there, sort of talking the talk but not really walking the talk, and they're just inherently conservative, really. So Lawrence has asked, what can be done to get research funders and their funding committees to fund more research taking a systems perspective? So both UKRI type funders who fund more mechanistic exploratory research, and NIHR type research which is more focused on interventions and solutions.
Thanks, Lawrence. So Lawrence and I have both been trying to work on this, and I guess my first response to it is appreciate that this stuff takes time, and the older I get, bizarrely, the more patient I get about this stuff, because actually things just take time. And my sense is that over the last 10 years, and particularly over the last 5 years, we have seen some quite significant changes. So I think you're right that people are, the rhetoric is there, but it's not yet matched by the reality. But 10 years ago, the rhetoric wasn't even there. And I think we are seeing shifts. UK PRP, I think, has not gone as far as I might have hoped it would have done, but I think it has. It's been a really good attempt, at least, to try and do this, and it's an important step along the way. It's absolutely not taken us to the end of the road with this, but I think it's an important step along the way. I also think that I think that the arguments in favor of, I'm not arguing for chucking out the old stuff. I'm just saying there are some things for which we need these newer kinds of approaches. And I think the arguments in favor of thinking systemically, looking at these kinds of interactions are, I believe, overwhelming. I think we are failing to deal with some of the massive problems that we are faced with. And imagining that everything can be dealt with through the kinds of ways we've been trying to deal with it over the last 10 years is just delusional. So we've got to do things differently. And yeah, I don't know. One of Muir Gray's lines is, where there's retirement, there's hope. And I think these things change, these things turn over. Lawrence and I think many others are finding that there is a real shift. I hope you agree with me, Lawrence. I think there is a real shift, and it just takes time. And, you know, one of the biggest failings of the COVID-19 pandemic is that many politicians don't understand exponential growth. In the early stages of exponential growth, it looks like nothing is happening, and then it takes off. And I'm optimistic that actually we're in the early stages of change here, and it is and will start to take off, but it doesn't really come through yet.
Okay, that's great. Thanks, Annie. So we also have a question from Valerie McNeese. So she's asked, what are your thoughts on how to manage the tendency for short-term investment in public health interventions and a need for quick wins driven by politics versus the need for longer-term investment in upstream preventive measures to bring about real change in our public health?
So yeah, great question. And I kind of fudged over this. But when I talked about the 20-year vision, 5-year strategy, 1-year plan point, this was really about taking putting my money where my mouth is and taking a complex systems approach to thinking through how one gets stuff to happen. And this came from when I was doing some work advising the Greater London Authority on obesity while Boris Johnson was mayor. And we had to think through what were the kinds of things that might need to change within London to, you know, the remit we've been given is, you know, what are you going to do to change obesity in London, you know, really have an impact on obesity in London? And to think that one could do that over the course of a single mayor's term was ludicrous. It's taken us decades to get to where we are. It's going to take us decades to reverse this. What does one do? And what we got to was thinking through, I had a conversation with a brilliant guy called Mark Brown, really great colleague of mine, who said to me one day after we'd been running a workshop, Harry, this is great stuff, all very clever, aren't you smart, lovely, lovely, 20-year paradigm shift, blah, 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 yeah. What does year one of a 20-year paradigm shift look like? Fantastic question. Because what it got us to do was really to think through, what does year one of a 20-year paradigm shift look like? It's all very well to say we've got pie in the sky for 20 years' time, but what does that mean? And what we then had to work out was, okay, and we did lots of consultation on this, lots of engagement. We got a kind of agreement on what our 20-year vision was, but then we had to say, okay, what is feasible within a 5-year political cycle with a right of centre mayor? For whom it is entirely appropriate, that a senior decision maker wants to know, what do I do now? So we had to think through, okay, what's politically feasible within the current political cycle? What should we say to Boris Johnson when he says, what do I do now? What are my 3 things I do this year? And how is all of that congruent with a pathway to where we want to be in 20 years' time? So instead of just, and this is where the chess point comes in, instead of just saying, what do I do now? We say, where are we heading? What's the context? What's feasible? And how do we make this, how do we make the step along the way that might look exactly the same as the step along the way we would have made otherwise, but how does it fit into a pathway that might help us to get somewhere? I think the other bit of it that perhaps relates also to something I should have said when I was responding to Lawrence's question is some of this is about Trojan horses or Trojan foals, maybe. They're not quite as big as a horse. It's get the ideas in there as part of other things. So one of the ways in which I think we shift the research agenda is not by suddenly going all out radical, we're going to chuck everything out. We say, we're going to do all of this, and as part of it, we're going to try and increase our understanding and learning about whether or not these things make sense. You know, I might be wrong on all this. Test it. You know, I'm a scientist. You know, I'm happy to be proven wrong. You know, let's build that into our research projects.
Thanks, Harry. And we have a question from Eric Ingelstrom, and he's asking, in terms of improving the evidence base on the left-hand side of the Swinburne diagram, how far do you think this is likely to be about new or novel methods, i.e. the complexity science stuff you mentioned, versus reappropriating old-fashioned methods to ask different questions?
So I'm not sure I understand that question, and I'm sorry you're not able to have a conversation with me about it, Eric. I think that, so it depends what you mean by old-fashioned methods. So, you know, there's plenty of really valuable and important qualitative research. There's plenty of ways in which we can examine the effects at population level of macro level interventions, such as changes to agricultural policy or whatever. But there is a really powerful dominant narrative that says everything's got to be not everything, but you know, that privileges trial evidence above other forms of evidence, even where trials are completely unfeasible. And the other bit of it, I think, so I just think that's wrong. I've got nothing against trials. When you can do a trial, do a trial. But for lots of this stuff, you just can't. And I think the other bit of it that we need to engage with much more is this point about adaptation. Because, you know, the head of Coca-Cola said, there is no evidence that introducing a sugar-sweetened drinks tax will reduce obesity. He's absolutely right. I wouldn't expect it to reduce obesity. It's one of those sandbags. Let's not set it up to be the, you know, a single intervention in this messy, complex system. Let's not pretend that it's going to solve the problem. Let's work out what are the tools for assessing the contribution of something like a sugar-sweetened drink tax or whatever it might be, one of the sandbags. How do we appropriately assess the contribution that any one sandbag can make when that sandbag on its own can't possibly change the whole system, and the system will adapt in response to that sandbag if it's the only thing you do in the first place?
Thanks, Harry. I think we're just about out of time. Sorry to the rest of you, because Lauren's had a few more questions in there, and there's a few other people who've put questions in the Q&A. But sorry, we're running out of time, so we're probably going to need to wrap up. But thanks, Harry. Could
I just respond to Mike Lean said I was being negative about product reformulation. I wasn't, and if I gave that impression, I'm sorry. I didn't mean to give the impression that it was, I wasn't being negative about reformulation at all. I was saying that was a positive effect, a positive adaptation, not a negative one.
Okay, thanks for that clarification. Yeah, so great session, and yeah, I hope it's given people a lot of food for thought. It's obviously a big challenge trying to use these kind of approaches and change your way of thinking, but it's, for many of us, I think it's definitely the way to go. So great session, Harry, and thank you so much again for delivering.
Thank you so much for inviting me, and I'm just really sorry it couldn't be done in person. Next time, I hope.
Lots of remote clapping that you can't hear, but thanks a lot.
Stay safe, everyone. See you.
Thanks, Harry.